really appreciate it. This is really a passion topic for me. I'm going to look at more of the pre-injury side of things in terms of risk factor. I know we have some really good speakers that are going to talk about some really cool topics in terms of the quad post-injury, but I felt like this is an important topic when we're looking at the actual risk factors for injury in terms of ACL. So I'm going to be talking about the neuromuscular risk factors for primary ACL injury, with sort of the overarching question being, how should we screen athletes in terms of, testing protocols, environments, things of that nature. Just to give a very brief overview, was from Michigan State University, schooling in engineering, kinesiology, and then moved on to master's and PhD in lower extremity biomechanics from Ball State and UNLV. Spent some time with the Tampa Bay Rays baseball organization. Then after my PhD, went on to Emory, spent some time as a postdoc researcher, and then recently have joined Clemson Athletics as their director of Olympic sports science. So the first thing we need to talk about when we're looking at risk factors for ACL injuries is just generally, how do ACL injuries occur? And there's a couple different ways from a primary injury standpoint. Thought I'd show just a couple of different videos here. These are not injury situations here, but they represent the patterns pretty well. So we'll see there an athlete completing a header, and then we'll also see an athlete performing a jump cut here as well. See some of the kinematic data as well as some of our force plate kinetic data. And so when we're looking at the actual events in terms of how an ACL injury occurs, generally a few patterns exist. All ACL injuries present unique situations, but some of the things that we often see is large ground reaction forces, large landing forces that occur in a very short amount of time. From some of the data that we've seen recently in terms of actual ACL injury events, it's estimated that within the first 40 to 60 milliseconds, the ACL injury will actually occur. So very, very fast, a very, very rapid loading onto the ACL itself. Something that we also may see as well in terms of the ACL injury is an extended lower extremity posture. So an extended knee position, as well as a rear foot or potentially like a flat foot sort of landing style. We also may see in terms of some of the frontal plane contributions. Obviously, ACL is very multifactorial from a biomechanical standpoint. So we may potentially see dynamic knee valgus and or large knee abduction or knee valgus type of moments, where you'll see potentially the landing forces laterally to the knee joint center, potentially placing them to a valgus type of posture there. And then some of the other factors that I've really been exploring the last couple of years is this idea of sensory-motor integration, how that affects neuromuscular patterns, biomechanical patterns during these types of movements. And what we're often seeing now in terms of actual ACL injury events is athletes are being placed in, the best way to describe it is unanticipated situations, whether it's from landing, jump cutting, trying to navigate around a defender, receiving, a pass, passing a ball, things like that under these time and spatial constraints. So that's kind of what we're seeing right now in the trend in terms of when these ACL injuries are occurring. And so the real question becomes now, how useful are screening protocols for actual ACL injury risk? And how I like to think of it now is they're as useful as the actual mechanisms of ACL injury. So we see about 70 to 80% of ACL injuries can be classified as non-contact or indirect contact. You could see potentially a perturbation in the trunk area, so not direct contact to the lower extremity or the knee. What we often see very commonly is ACL injuries occur during single leg deceleratory movement across a couple different movement planes. So it could be a jump landing, could also be a jump cut scenario, but typically ACL injuries are occurring with the body weight primarily loaded onto a single limb. It's more rare that you'll see a very evenly distributed loading pattern during an ACL injury. As I mentioned before, what we're seeing now is this flat foot and extended knee posture. And some of the more recent data has shown that Valgus isn't necessarily present in every case. In some of these larger scale studies from a video analysis standpoint, we're seeing valgus presence in about 50% of actual ACL injury events. And as I mentioned in the previous slide, this idea of sensory motor integration, where we're seeing these events occur under divided attention, external focus type of conditions here, where they're fixating on an object or they're avoiding a defender, is typically where ACL injuries are occurring. A very recent example in the Super Bowl, Rams wide receiver was actually turning his head, looking to catch a pass, and then performing a deceleration there. We saw a re-injury there of the ACL. So generally some patterns that we're seeing from a mechanistic standpoint. But when we're looking at the actual neuromuscular risk factors for primary ACL injury, we got to think about it in kind of define neuromuscular. So it's the nerve, the nervous system, and then the musculoskeletal system. When thinking about the nervous system, we're thinking, central nervous system, the brain, and the spinal cord, and how that's influencing movement behavior, how it's influencing sensory processing of information, and then ultimately how that's feeding down into the biomechanical or muscular behavior there. So we're looking at some of the risk factors, and when you think about with risk factors for ACL injury, looking at it in terms of just univariate risk factors can lead you down to some tricky paths just because this is such a multifactorial injury. But I'm going to overview just 4 areas of consideration with the understanding that these are interactive factors here and dynamic sort of behaviors here that can change. So the trunk and the hip, the knee itself, the lower leg, which I define as, the ankle foot segment, and then lastly, touching on some of the sensory motor factors that have been presented in some of the more recent literature. So I'm looking at some hip and trunk risk factors. These are some really, really good figures by Powers et al. In terms of the influence of abnormal hip and trunk mechanics on actual knee loading, and some common patterns that we may see in actual ACL injury events is this idea of lateral trunk sway. You'll see in figure, in C here, we're seeing when the trunk deviates laterally, potentially that ground reaction force actually moving lateral to the knee joint and potentially placing an additional abduction torque around that knee joint. So definitely frontal plane deviation of the trunk, lateral bending of the trunk could certainly present as a hip and trunk risk factor, but also an upright trunk posture as well. Again, really, really good figure here from Powers kind of demonstrating that. We'll see when the trunk is more in the erect position, we'll actually see that moment increasing around the knee joint. The distance between the ground reaction force vector in the yellow there is actually further away from the knee joint center compared to when an athlete or an individual is performing like a jump landing with a more flexed trunk posture. So an erect trunk posture could certainly present as a risk factor because it increases the extension torque around the knee. There are, from this standpoint, potentially performance and injury risk trade-offs in terms of an erect versus a more flexed trunk posture, but just from an actual loading standpoint, typically see less knee torque in the sagittal plane with a more flexed trunk posture. In terms of the actual risk factors around the knee joint itself, and something that we really have to understand here is that relative to the hip joint and the ankle joint, the knee joint itself has relatively limited motion and is certainly influenced by the behavior of the hip joint and the ankle foot complex as well. But as I mentioned before, the dynamic knee valgus posture, not necessarily present in every single case. Some of the more recent data is demonstrating it's only present in about 50% of cases, but what we're seeing now from some of the video type of analysis is much more higher prevalence of an extended knee posture. This is an example from a few years ago of a football athlete. Again, just a single shot here, but I thought it presented it very well, where is that rear foot landing, that extended, close to almost hyperextended knee posture, that initial ground contact, keeping in mind that we're seeing these events typically occur within the first 40 to 60 milliseconds. So potentially that extended knee posture may be the primary risk factor in terms of just the knee joint itself, as opposed to being more heavily influenced by actual dynamic knee valgus. So just something to keep in mind. What we also are seeing is that potentially knee valgus is occurring, at least from a peak knee valgus standpoint, after the actual ACL injury has torn, or the ligament has torn, excuse me. So just something to keep in mind. We're looking at knee biomechanics and knee risk factors. In terms of the ankle foot and some risk factors there, again, very multifactorial. This idea of a rear foot posture versus a forefoot posture. And when an individual does land in more of a rear foot, flat foot type of posture, what we'll often see, and this is in running, jump landing, things of that nature, an increased loading rate, because we haven't gone through the dorsiflexion to start attenuating some of this energy during landing. It just, we hit that big thud there initially. So we'll see potentially an increased loading rate initially during that stance phase, whereas ankle plantar flexion initially upon landing allows us for some energy attenuation through dorsiflexion, and that can also help synergistically with subsequent knee flexion and hip flexion as well in terms of energy attenuation. And so those are more of the, I suppose, biomechanical, like macroscopic type of risk factors, you know, from a screening standpoint. But I thought it was also important to touch upon some of these sensory motor risk factors and some of the things that I've been exploring more recently as it relates to ACL injury, because we're seeing more and more now this idea of neurocognition, sensory motor performance directly influencing motor behavior and movement biomechanics, which could in turn influence how you're screening your athletes and some of the actual information that you're gleaning from these injury risk screens. And so I like to break it down into just 5 sort of macroscopic variables, at least at this point. Certainly much more research needs to be done in this area. It's relatively in its infancy compared to the more established neuromuscular biomechanical research. But visual attention is one, certainly where we're fixating visually versus where we're kind of blocking out some of that noise. Reaction time and processing speed, how quickly an athlete or an individual is able to process some of this visual, auditory information, and then, you know, make a subsequent movement or movements in a complex. Certainly another potential risk factor. There's some data there from Gary Wilkerson in terms of the relationship between reaction time, processing speed, and lower extremity injury risk in collegiate athletes. Another one, certainly an important one, is working memory, this idea of short-term memory storage. We have to think about when our athletes are in a chaotic athletic environment. There's a lot of going on there. They have to, you know, recognize patterns. They have to anticipate situations. They have to retrieve, you know, memories based on, you know, concepts that the defensive team is presenting in front of them. So that's certainly important. Will certainly influence how they're moving within space. Impulse control, potentially another factor here from a sensory motor standpoint. Knowing when to react to something, knowing when to kind of let that go, could certainly influence movement behavior, when to decelerate, when to make a movement, when to navigate around a defender. And then lastly, but certainly not least, because this is certainly an important one, is stress and anxiety. High levels of stress, anxiety, tension, whether it's an acute or chronic state, can certainly influence all of these other aforementioned variables and possibly present as deficits from a sensory motor standpoint. And from an actual screening standpoint, how we're kind of looking at this and quantifying it, there's a couple different ways, at least at this point in the literature, from sensory board type of technology, virtual reality technology as well. Subjective questionnaires can certainly provide some utility as well from like a stress and anxiety management standpoint. So those are some things that just consider in terms of risk factors from a sensory motor standpoint. And I suppose the overarching concept here and theme in terms of what we're looking for in terms of an ideal injury risk screen, there's never going to be that perfect screen. We'll always have certain limitations that we need to consider, but one is attempting to have these movements best replicate the actual injury scenario. So one would be a single leg type of deceleratory movement, so a jump landing, a jump cut, something that is occurring in multiple planes, so not just sagittal plane type of dominant movement. We're getting potentially some rotation, we're getting some frontal plane movement as well, and then also including some sort of anticipation condition or reactionary type of condition, because we are starting to see how this is potentially influencing movement behavior and potentially overall ACL injury risk. Oh, sorry, I should just leave it one more thing here, sorry. In terms of what I'm kind of proposing now as my pathway to ACL injury risk, starting from a sensory motor neurocognitive standpoint, when we're having some deficits in attention and processing speed and memory, potentially leading to this idea of a mismatch in perception action. So mistiming when the defender is actually coming from a trajectory standpoint, which could then relay to a delayed neuromuscular response and potentially increase tissue load on the ACL, which leading to a higher risk of injury. But then knowing what we know now from a sensory motor standpoint, there's opportunities to sort of modify these risk factors in conjunction with established neuromuscular and biomechanical interventions to hopefully reduce the risk of injury and more successfully screen for actual ACL injury risk. That's my finisher there.